Okay, I think maybe start something simple. Linda, a question is, and I think that builds on what we just said, and I may be wrong, but I think that probably bile acid diarrhea is probably the most severe form of a chronic GI destruction, correct? Would you agree?
Yes, absolutely. But these are usually the worst, most difficult to treat ones.
Exactly. So that's why if the question comes up is, have you ever seen this in young dogs or puppies?
Not as far as we know. Koba, the Siberian Husky that was in the case report we published, he had problems since he was a puppy and he didn't respond to anything. So I think he had it since he was little, likely, but I think it built up over time and because it got progressively worse. There are some interesting studies in kids, actually. So babies and infants with diarrhea that were hospitalized in Finland, and they gave them cholestyramine low dose, and they could send them home quicker than they could for the babies that only got supportive care. So I think it could be possible as a consequence of acute diarrhea as well, but then it should be self-limiting, so nothing to worry about. It would be so cool to do a study in acute diarrhea and see what happens if we could actually make them clinically better, quicker with that. But there are some side effects with it, and they have a poor appetite if they have acute gastroenteritis, and then cholestyramine may be difficult to get them to eat. But no, I haven't seen it in puppies.
And that's just to follow up on this one. So again, we believe it's really this long-term destruction of the GI tract, and that will also make sense that most likely they're going to need it for many years, correct?
Yes, absolutely. And I've seen the ones I'm following that, we have submitted samples for them, and most of them, over time, they still have super high disposal index and really low Clostridium hieronymus, but they do fine. They respond to cholestyramine and treatment of the underlying condition, so the inflammation that is there, but the disposal index often don't get better with treatment.
Yeah, and again, it makes sense because the disposal in those cases mostly is really, or the dysbiosis itself is caused by these chronic changes in the structure that never, very rarely normalizes. So we're managing the disease and so on. Perfect. Andy, everybody, and Helena, everybody comes back to the diet. So, okay, I think we answered already. It was a high fiber diet. I'm sure you don't know exactly the fiber sources, but I think everybody can look up what is in this diet. That was one question. Beautiful question comes always, and maybe I know Linda's take on it, but Andy and Helena's, I'm sure you also have this when you are in clinical practice, antibiotic usage. How do we tell owners not to use antibiotics?
So I think you have to tell us who should start.
Let me ask Linda first. The second question was also mechanism of tylosin. I mean, you can maybe combine it. I mean, it's probably the same.
Yeah. Well, where I work in Sweden, it's not that difficult any longer because we have very restrictive use of antibiotics both in humans and in dogs. So it's not that difficult. It was more difficult when we became stricter. But we talk about problems with people. One health perspective, we know that antibiotic resistance genes can be shared in households between dogs and humans and cats. And then, of course, there's a huge risk of spreading resistance genes. And just this year, a study was published in Lancet about death of antimicrobial resistance. And about 5 million people died from that in 2019 before COVID. So if we could actually risk the health of kids in a household, because there are often kids with dogs and cats, because we're giving this dog tylosin for months and months and years, then most people actually would understand that. So that's one of the things you can actually talk about. But if we look at antibiotic resistance, WHO find that one of the biggest threats to mankind, and people understand that usually.
And tylosin, what's the pros and cons of tylosin in chronic diarrhea?
Yeah, I mean, the pro is, of course, that many dogs respond to it, so the diarrhea improves, but it's a disaster for the intestinal microbiota, and it's the same problem as I talked about just before, that we know that there can be sharing of antimicrobial resistance genes between people and their pets, and also a lot of vets justify this by saying that, okay, tylosin is an antibiotic that is not used by people, so it's safe, but it's not. It's shown in pigs that if you use tylosin a lot, then they develop a erythromycin resistance quite quickly. And erythromycin is important for people with various allergies to antibiotics. So that's the first line treatment if you're allergic to penicillin and other types of antibiotics. So yeah, tylosin is not safe either. But yeah, the pro is that they often get better, but you can't stop the treatment. So that means that you will spread out so much antibiotics in the water system and also for this animal.
So just to clarify, so it means usually you cannot take them off anymore? What do you mean with not?
Yeah, exactly. And that's been shown in Karen Allensbach's study when they followed dogs with chronic enteropathies for 1 year. So they classify them in antibiotic responsive, food responsive, and steroid responsive. And the antibiotic responsive ones, 100% of them had relapse within 1 year. And the studies from Finland, from Kilpinen and Westermark shows that 88% of dogs responding to tylosin will relapse within a few months. So that's huge. So I don't think we actually treat the underlying condition. We only stop the worst clinical signs and lower the pressure of antimicrobial of microbes, but it's not a long-lasting treatment.
Mm-hmm. Helene and Andy wants to start. I mean, so the question, when you did those studies, obviously you had to enroll patient owners, and were there any concerns? What is the, Helena, what is the, or even AHDS, I mean, that most dogs would say, well, most owners, would they be concerned if you don't give them antibiotics? Because that was not plan of your study, correct? It was clear that antibiotic was not a first choice, correct? Was there any concerns by owners?
I would say no, because I think it's a disease which is not so present, and the owners don't know so much about it. But if you say, okay, we know that there's an overgrowth of a bacterium, then you often have the discussion with the owners. But the most time, or the biggest problem we had was that they had concern with the FMT treatment. But I think I had just 2 discussions with owners about antibiotic treatment, and I said that it has also side effects and also like the resistance, and then the most owners understand it and said, okay, and like we said, okay, if we have like signs of sepsis and we need an indication, or we have the indication we need an antibiotic treatment, we won't resist to give it. So I think that's was the way that the owners felt safe in the clinical treatment.
Mm-hmm. Helena, you have I thought you have a study about also owner questionnaires, correct?
Yes, I had a study. It's a survey for owners, so it's about acute diarrhea as well. And the focus of the study is the knowledge from owners about antibiotics, and I asked them about negative effects of antibiotics, and the study showed that 50% of the owners don't know about negative effects, and the other result was that only 12% of the owners want an antibiotic in acute uncomplicated diarrhea, and 50% of the owners said that they will be happy about the information from the veterinarian. So we concluded that a lot of owners will be happy if we explain about antibiotics, and so there's a big potential to do education for the owners about antibiotics, so they're happy to have information from the veterinarians.
Mm-hmm. Quickly, what was the iohexol dose that you used?
Mm-hmm. It's 2 ml per kg of iohexol, and it's Omnipac 350.
Okay.
It was.
Okay, for your study, was there anything in the clinical history to indicate which dog may be more likely to have low albumin and severe damage in the gut barrier? Yeah,
actually no, but I think we will show, or we will see if there is a correlation between the serum iohexol concentration and the duration of the diarrhea. So when did the dogs develop the diarrhea, and when were they presented in our clinic, and when we did the serum iohexol concentration, was there a correlation? But we did not do the statistics yet. But I think otherwise I couldn't see anything no correlation or stuff like that.
Do you think those dogs are different somehow in the history, or that have HDS? Are they already somewhere, or do they come back usually? Or we don't know.
I would say that often the owners said to me, like in doing all this, saying, okay, does your dogs have any chronic signs? And the owners often say no. But then if you say, oh, and what about giving him some different food? They often say, oh, he have a sensitive stomach. And so I think often the dogs have like chronic gastrointestinal disorders, what are maybe not so worse that the owners see it as a problem. But I think that's a problem we all have in everywhere.
Mm-hmm. Perfect. Kelly, I have no idea what is a para postbiotic. Para probiotic. What is that?
Yeah, that's another term I think that's been kind of used for that. And I think on the expert panel that was it with postbiotics was trying to take a lot of these. There have been a few terms like that, the paraprobiotic and others that I think are really meant to describe the non-viable, like the inactivated basically microorganisms. And so I think the panel was trying to say, oh, let's use the same terminology going forward. So I think there have been a couple of papers on using that term. And so I think, yeah, it's meant to be the same thing, whether they're actually the same or not. It probably depends on the product, but.
Mm-hmm. Now, a few questions comes about, risk factors for later diseases. So I think in humans, there was a lot of interest about C-section versus normal vaginal section, and how does if the moms, if they get antibiotics, is there anything out there that we can, how big is the risk really? Is it really a huge effect? And second, is there anything known about dogs and cats?
Was that to me or somebody else?
Of course, to you.
Oh, me. Okay. Oh gosh, I don't know. I've attended conferences where, again, we're talking about C-section versus natural birth, and I guess what's often not measured is was it nursing and breast milk after that, or if it's formula fed. I think that's a big factor as well. If you think about not only the nutrients in breast milk, but the immune factors, and especially early on in life, that I think a couple other people have kind of mentioned that early on in life, that stability is just not there, whether it's the gut itself or the microbiota. And so I think that's a pretty important life stage and can kind of set the path. But again, there's a little bit on the postbiotic side. You have to be really, of course, really careful with infants, and just like young puppies and kittens, that I think it's more, they're more impacted by the treatments potentially, but you'd have to be, always be careful with the dosages. And I don't know if I can speak any more than that without just rambling on and guessing at things, but certainly I know that the life stage, certainly I think when you think about diseases, what do you target and what might be a strategy to target it, I think that also could apply to different life stages. And if it's, young growing animal versus adult and quote unquote healthy versus then you get into a disease state or geriatric state, I think you could make an argument for a different treatment at every point there. And it really, probably depends on the situation, and if you can identify what's a cause of a problem, that's then trying to target that.
How can, when we're going to give antibiotics, is there any benefit of giving prebiotics, fibers, or symbiotics as a prevention or amelioration? Is there any evidence behind it?
We've looked at that lately a couple of times. I know we've sent some samples to you guys down in Texas. So we haven't published that yet, but we have a couple papers that are in the process. One's under review right now. That I think that's at least part of the goal. And I think, I'm not a nutritionist. I'm not in the clinic, but you hear that with probiotics quite a bit. But I've had some recent sponsors looking at that from a prebiotic or a postbiotic, just to see if part of it depends on the study design as well. Is do you give it right as you give antibiotics, or do you give it? I would say, I'd argue, try to give it beforehand to try to set up, if you're going to set up a barrier, if you will, to strengthen, change the microbes, or, tighten up the barrier function, whatever it might be, to give that, and then see if they can kind of resist some of those changes or impact, the resilience, like how quickly they come back. And so I think the jury's still out, and it probably certainly would depend on the product in particular. But I do think, I know, I guess from experience, I know people are interested in kind of looking at that and seeing if they can show that, yes, if you have to give an antibiotic, and I agree with the others on the panel here, that if you can avoid it, with certain conditions, they're really going to resolve themselves if you can avoid giving the antibiotic. But If you reach a point where you have to, well, then, okay, again, you're going to alleviate, I think, the initial, like Linda said, maybe the clinical signs that are there, but, you know, long term, you know, when can you move them off, and are they going to relapse? And so if there's some other interventions, I think people are looking into that, and hopefully there's something, again, to kind of help support, you know, the gut directly, but also through the microbiota.
Great question, because there's a combination of two things. We know that dogs with AHDS normalize pretty quickly. I think we have this, you know, microbiome data and NF data and so on, but we also know there's a risk factor. So maybe some of them over time, and so would make sense to look in postbiotics there, or something that potentially, and if so, which pathways would you actually look at? I mean, what pathway could actually really affect the gut health, preventing this, you know, from acute damage and preventing becoming chronicity?
Yeah, that's a great question. Okay. I'm not sure
I have the answer, I guess, and we don't know it, but the concept I think would make sense.
Yeah,
Linda, quick question for you. When you give cholestyramine, do you specifically look at the diet, or is the diet the same that you would give because of the chronic enteropathy? Or are you concerned about fats and cholestyramine or something, or are you not worried about that?
No, not really. Typically, these dogs are on hypoallergenic diets, but some of them are on homemade balanced diets. And I see if we increase the cholestyramine a lot, that cholesterol decreases. And I've seen worse cases than Folke that had a minor increase in cholesterol. One dog that was moving to the UK, super stressed. So diarrhea got back when they were about to move. Increased corticosteroids, we responded to that, but we couldn't decrease the corticosteroids. So then I tried cholestyramine to save some of the corticosteroids, and that worked very well. I told them to decrease the dose. When they got to the UK, they didn't do that, moved back 1 year later, and the dog was on really high doses, and he did fine, but his cholesterol was like half what it was supposed to be, so he's now stopped the cholestyramine. So I think it will happen if we give high doses. I don't think so much about the diet more than a diet that they have the least clinical signs on. That's the diet I would choose. And some of these dogs that respond to bile acid sequestrants, they get much better if you change the diet again. So diet is really a key factor for all types of chronic enteropathies.
It also comes with the question, have you looked at the impact of diet on the accuracy of the disposal index? I can answer that, yes, we did. And I think it comes back to the same concept. There must be major changes in the microbiome, or something that really shifts the whole microbiome. And so yes, diet has an impact on the micro, but again, it's all the perspectives. If you focus on something small, you're going to see changes. But if you put this in a big range of normal, it's not as a huge shift. And so that's why if the diet is generally balanced, or the norm of diets, then we don't see any change. And Kelly and I actually did a recent study looking at all those different diets. We didn't see any change. The one thing that we saw only is dogs that have homemade extreme diets with high protein, high fats, low fiber. They usually have an increased disposal index, but they usually have a normal glucosaminosis. So again, we see those patterns are different. And I think that's important to understand. We need to understand what is clearly abnormal, and then there's this huge range of normal, like in any other organ system. And I think that can help us differentiating that. And the other question was maybe for you, Linda, for everybody. I mean, I don't know, in Germany or in Sweden, that's more a clinical question. What happens if an owner comes with their own microbiome / other panels from other companies that are not validated? How do you react with that? Is it common in Sweden or?
No, I haven't seen it. Well, actually, yes, I have seen it once. And of course, since it's not validated, I don't trust it to the same extent as a validated test. That's actually one of the dogs that was a non-responder, didn't respond to absolutely anything. So I don't, but the disposal index when I sent it to you was actually normal in that dog. So it was probably just overwhelming inflammation that we couldn't control. Mm-hmm. But normally I would say that I would prefer to check a test where there's a validated outcome and we know what it actually means.
Exactly. I think that's probably for every test important, especially when gut health. Let me see. We already talked about probiotic. So the question was, if you have to use an antibiotic, for example, skin disease, can a probiotic help? I think Kelly kind of answered that. I think there are studies out there, and it depends on the antibiotic, but most antibiotics do more change than a probiotic can ever prevent, because we just have so much bacteria. And I think that's also a concept that people don't get often, how much bacteria are truly in the gut. It is really a jungle. And that's why you cannot change it easily. You cannot change the microbiome easily. The microbiome changes if something major happens. And antibiotic is like the fire, or you have this really chronic changes on the gut flora. And if they're acute, that's actually fascinating. Acute, every normalizes quickly. And I always compare this to, if you dig a hole in a normal backyard today, in 1 week, the grass is going to grow over, correct? You still may have a hole, it's still long-term a change, but initially it is. But if you want to plant something in the Sahara where they have no diversity, you can plant as much as you want. It's going to die off. And I think that's the same concept. We slowly have to see those are major changes here that we see and so on. And that's why studies have shown that when you give probiotics, in some studies, the microbiome recovers a little bit faster, but the dysbiosis cannot be prevented. And sometimes the clinical symptoms may be a little bit less. So yes, there may be usefulness, but it's not really preventing the dysbiosis, if that makes sense. And it actually comes also back probably the same explanation what we have with cholestyramine dogs. You give an FMT and you cannot even bring the microbiome back. And if you cannot bring the microbiome back with an FMT in those really severe conditions, it just shows you how severe abnormal the GI tract is and so on. So I think that's also probably a new concept that we pretty much, we're discovering, but I think it makes perfect sense.
Yeah, and I think it's valid to mention that if you give antibiotics and the dog or cat has problem afterward, FMT is a very good way to restore the dysbiosis that is created by the antibiotics.
Exactly, yes. I think we're going to have a little bit, but yes, I agree. And Fabio is going to probably have a very nice case tomorrow. Tomorrow we're going to have fiber and FMT, but we see that if there's just antibiotic-induced dysbiosis, FMT works really great. If there's GI damage, FMT can work clinically. It can help transiently, but we know it's going to be a long-term repeated management tool and so on. And I think, I think this data is pretty strong now, correct? Would you agree, Linda?
Yes.
This concept, yes. Let me see. We all talked about the test. Do you ever think that bile acid testing is going to be specific? Are we going to have a test that is really going to be specific, or is going to be just it's still going to be much of a clinical experience? So
no, I think that the percentage of primary and secondary bile acids will be a super good test in the long run, and also C4 if that can be combined, because with one test you won't catch every type of bile acid diarrhea, but I think that will be a very valuable contribution. And every time I get the test results back from Jan's lab for my severely ill patients, it's like Christmas Eve, because it gives me extra light on the patient. And also the patients I treated that didn't respond to bile acid sequestrants, I didn't know the fecal panel of those dogs before we treated them. If I had known, I probably hadn't started them on cholestyramine, because they didn't have any changes of the secondary and primary bile acids. The relationship was normal.
But also just important to mention, at the moment, there's no lab, to our knowledge, that commercially offers bile acid testing for feces. I think some labs offer total bile acid, but again, we showed that it's not useful. You would have to really use a specific method, primary to secondary bile acids. So at the moment, the only test available is dysbiosis index that can give a hint, but it's not the same like a bile acid testing. I think that's important.
And I guess in a few years' time, it will be a standard test, hopefully.
No, I mean, I think it's again, we're working on it. And I think the more data we have, the more clinical data we have, and we can really predict better, then I think we are ready. But at the moment, we don't have enough cases where you have strongly says that's really a bile acid diarrhea case. So, but we're working on that for sure. Andy and Helena, one quick question, and I don't think you know the answer probably because you didn't do endoscopy, correct? But there was the question when you speak of vets observing sepsis in some of the patients, was there any incidence of GI perforation?
No. So no free fluid in the stomach or something like that, no.
Okay. Perfect. Okay, I think we have all the questions. Anybody on the panel has some other questions or something important that you want to that came up and you didn't have the chance to yet maybe add your comments to that?
I can just add one more thing, and that's about the retrospective study we made on FMT in chronic enteropathy, that the ones that had the most normal microbiota responded the best. And initially, I thought that the ones that had worse dysbiosis would be the ones who needed the FMT the most and would respond the best. But then you can think of it as the garden Jan talked about, that if the soil is super poor, like you have severe dysbiosis, then the transplant, the new bacteria, will not be able to proliferate there. So I think that's what's happening. The environment is so changed in this gut. So even if you give FMT, it's not going to be enough for engraftment.
And it makes also sense that those mild cases are probably less severe affected, hopefully. I mean, that's the concept we're working in.
Yeah.
And very last question that just came up, antiparasitic medications and the warmers affect the microbiome, like antibiotics. We only know of fenbendazole, and it did not. There was no change that we saw. So I think there's clear difference if you use fenbendazole versus metronidazole for some infectious like Giardia and so on. Perfect. Great. Yeah, so I would like to thank everybody. I think for tomorrow, I want to just also say that tomorrow we have another day, great speakers. We're going to talk about fiber, practical approach in fiber. Prebiotic is a concept, but I think, and maybe Kelly can define what actually fiber is with a prebiotic. But I think for me, from a clinical point of view, it becomes a little bit of a not gray zone, but I think an overlapping team and so on. And then we're also going to talk a lot of FMT. So we already heard today that FMT can be very useful in some patients. Some may not be important, but I think tomorrow we know more the concepts of chronic GI disease. So I hope you're going to join us, and I think have Natalia for a few final announcements. So thank you, everybody.